So at the outset, I'd like to thank APOS and AIOC for giving me this opportunity. And the topic for my presentation today is MRI, reading between the lines for ophthalmologists. So this will be an entirely case-based approach. I have no financial disclosures and all photographs have been used with full patient consent. So let us just start off by talking about this particular case. Here we can see an axial cut of a CT scan where there is an enlarged lateral rectus, but we can't really see any pathology within the lateral rectus itself, and it doesn't really help us to arrive at the diagnosis per se. So instead, if we get MRIs done for these kind of soft tissue lesions, here we can see a well-defined cystic lesion within the lateral rectus with hyperintensities within the cyst itself. And it does suggest to us myocysticercosis of the right lateral rectus muscle. So of course, everything has to be clinically correlated, but MRI is better in terms of soft tissue lesions, and of course it has the additional advantage of not having ionizing radiation. Similarly, this is another case where there is a CT scan was done for this patient. The superior rectus shows enlargement. We can't really see the pathology very well, but the MRI shows a very beautiful round cystic lesion in the area of the superior rectus with a hyperintense lesion within it, which probably indicates the scolex of the cysticercus larva. On the other hand, of course, there are certain cases where MRI may not be completely adequate. So here we have a patient who was a 45-year-old male presenting with a large mass in the superior and the superotemporal right orbit. It seems to be have progressively increased towards the cranial cavity. What else do we need to see in this patient? We also need to know the status of the bone in this patient before we go ahead with surgery or planned surgery. We need to know whether the outer table or the inner table of the frontal bone is intact, and CT gives us that nice delineation. And here we can see that it has eroded through the frontal bone. Of course, it hasn't entered the cranial cavity. We can see the dura is intact, but we should not take up this patient just in an ophthalmic setup without a neurosurgeon involved. Another similar case where we can see a hyper-intense T1 weighted lesion in the left orbit near the greater wing of sphenoid. We cannot identify exactly where in the greater wing of the sphenoid it is, but here on a CT scan we can see that the sphenoid bone is eroded in that focal area, and this was a biopsy proven case of Langerhans cells histiocytosis. Now let's come to this patient who was a 60-year-old lady. She had complaints of right eye proptosis for the past 3 months. She had movement limitation and slight decrease in vision in the right eye. So these are all the various sequences and the MRI images of this patient, and it gives us a lot of different types of information. Of course, like we can see right at the outset that this is a large, well-defined intracorneal lesion which is pushing the optic nerve laterally, and we can immediately jump to certain differential diagnoses like cavernous hemangioma of the orbit, schwannoma, SFT could also be one of the differentials. But let's look at what other information we can glean. So before going into the lesion itself, what are the respective sequences of these two MRIs? So we as ophthalmologists, we know that okay, vitreous is dark on T2 and vitreous is bright on T2 and dark in T1. We know that, but you know, we're not really used to looking at CSF. You're not used to looking at the brain. So it's something that we should also be aware of, that okay, we can't see the vitreous in here because there's no globe. So what are these respective sequences? So it's easy to remember. T1 weighting causes the nerve connections of white matter to appear white and congregations of neurons of gray matter to appear gray. So first picture is T1, second picture is T2. Another thing which is, you can see it's written TIR/M at the left corner of this orbital MRI picture. And what does it mean? It means turbo inversion recovery magnitude. It is also called turbo stir, and it is an effective method of fat suppression. So we know that the orbit is full of adipose tissue, which acts as an external contrast agent if it is fat suppressed. So this TIRM is nothing but another way of fat suppressing, and in head and neck cancers, TIRM has been found to give both high signal in tumor masses, and also low degree of overestimation of tumor size by reactive inflammatory changes in the surrounding tissues. Moving on, so this is another patient who had a large cystic lesion in the left orbit, and these are the 2E2 fat saturated images, which shows heterogeneously bright signal changes of the wall and dark signal changes within the matrix of the lesion. Additionally, the radiologist had also reported that there was no significant diffusion restriction noted within the lesion, which gives us the additional information that it is not a hypercellular mass. Coming back to our case, so on the left we see, so it was biopsy-proven schwannoma, cystic degeneration of schwannoma, and on the right we see a very similar looking lesion, intraconal lesion. So how do we differentiate it? Both are well-defined lesions, iso-intense to muscle on T1. So something that can help us is contrast enhancement. So on the left side, the schwannoma shows patchy enhancement on contrast. On the right side, the cavernous hemangioma will have contrast enhancement which spreads from the center. Let's look at this patient who was a 45-year-old male. He presented to us with left eye proptosis, congestion, watering, and eyelid retraction. At initial glance, we can see that the extraocular muscles are enlarged. There's a little bit of tendon sparing that we can see. But we have to look beyond this as well. So we have to be closely looking at other structures also, such as the superior ophthalmic vein, which is dilated here. We can also see that there are structures other than the internal carotid artery which exhibit flow voids within the cavernous sinus. So this was actually a carotid cavernous fistula. I have multiple other examples, but we don't have time, so I'm just going to go to the end of my slides, and I'm just going to say that we should look at the whole MRI, not only the area of interest, and always correlate radiologically. That means talk to your radiologist as well whenever there's a doubt, because they can give you a lot of insight as to, you know, what we are looking at in cases or in difficult cases. Thank you.
That was a good insight into the MRI and the importance, and always what I find is that quite often few radiologists only are very attuned to orbital anatomy and orbital lesions. Quite a few of them in their training course don't have too much of orbits dealt with, and we need to, I mean, I make it a point and tell my residents to make a point not to look at the report. First, try to clinically correlate, try to understand what is the units there, what is the diffusion, what's everything, come to a conclusion, go back, look at the report, and then, like you said, correlate with the radiologist. So definitely MRI and CT both have their roles in orbit, and though MRI has come in, you cannot say that CT is totally ruled out in orbital cases, because you sometimes do need information about the bony orbit as well, to plan your surgeries, to decide upon in thyroid, to decide upon whether it's a tight orbit, small orbit. Very interesting and educative talk. Thank you so much.
Thank you, ma'am.
And ultrasonography orbit also contributes, yes, especially in case of orbital cysticercosis. Yes. So that definitely additional value with MRI.